I've been in town about 18 months, but this is my third time moving to San Diego. I went to college here and I grew up here. And so I tell everybody this is the third and last time I'm moving to San Diego. It's good to be back. So I'm going to tell you some stories today, hopefully keep you interested. This is all public information. Feel free to tweet it. My Twitter handle is there. Now, first of all, I have to say that I don't have any conflicts with any of the material I'm going to present today, but I'm always looking for conflicts. So if you're interested, please let me know. Secondly, I want to say we are all or will be patients. So I have the good fortune of being a practicing pediatrician at UC San Diego. I see newborns every week there. Just saw a bunch of cute babies a few days ago. But unfortunately, I've also been on the other side of the patient experience. In fact, when I was in college here, I had a little bit of a trauma, was hospitalized at the Hillcrest Medical Center in the burn unit for several days, and lost function in my right leg such that I couldn't continue running, which was my pastime. So I took up bicycling, and for the last 20 years or so, I've been an avid cyclist. I was the road biker. You couldn't peel me off. 100 Ks, 100 milers, you name it, I did it. I've ridden all over the West Coast until I had a biking accident. So here I am at the top of a volcano in Hawaii and getting ready to go downhill. The bike accident actually wasn't in Hawaii, it was in Northern California, but I was careening down just about as fast as I had been in Hawaii. And unfortunately, I don't even remember what happened next, but I remember I woke up in the hospital with a whole lot of titanium, and they said I was going to have a bionic arm. Now, I actually broke both my arms. I had 2 separate surgeries, was discharged, and 8 days later came back with knee pain, and it turns out I had a DVT, or deep venous thrombosis. So what I want to tell you about a little bit today is how that experience being on the other side has informed what I do as CIO, how I run the information technology department, and I think that you'll agree when I'm done that both mobile technology and big data actually helped in my case. Now, you've probably heard a lot about big data. Where do you think we are in the hype cycle on big data? The beginning? Probably somewhere near the top, right? Big data is going to solve all your problems. So when you see signs for Walmart data, there's probably a problem. So we're up high at the peak of inflated expectations. But what I want to do is actually give you some real-world examples of big data and how it affects the patient experience. And we're going to start with physiologic signals. And for each of these, I'll give some examples both at UC San Diego, academics, and in industry. So thinking about physiologic signals, has anybody seen this app? This is the app that turns your iPhone into an EKG, right? Pretty phenomenal. It's already been shown to save some lives. Dr. Eric Topol is a big fan. The challenge that I was looking to solve when I was at Stanford practicing as a pediatric hospitalist was actually created by a company here in San Diego called Dexcom. Dexcom helped to revolutionize pediatric diabetes care with an invention called a continuous glucose meter. So you probably all know somebody with diabetes that pricks themselves 3 to 5 times a day to get those blood sugars. Continuous glucose meters actually sit on the skin, measure interstitial levels with just a continuous kind of probe, and they report out glucose levels every 5 minutes. That's 288 data points every 24 hours. So how do you manage that kind of data? The endocrinologists at my last hospital have been bugging me for 10 years. When are you going to put all the glucose data into our electronic health record? Now we've got 288 data points every 24 hours. In fact, with the recent FDA approval, you can now predict hemoglobin A1Cs because you have so much data, right? But you know who didn't have that data? The physicians taking care of those patients, right? And it turns out in pediatric endocrinology, things change a lot, right? Kids are going to summer camp, and on the weekends they're eating differently, and they're getting up at different times. And you need a lot of consistent kind of work with your endocrinologist to adjust those insulin doses. So we fired up a little project that was concomitant with an important announcement from Apple about an interface called HealthKit. So Apple said that iOS 9 or 8, I think, was going to have the ability to interface medical data in a standardized way. Our electronic health record vendor, which happens to be Epic, said, oh, we're going to be HealthKit compliant, and they were working together. And we were the third piece of that puzzle because Dexcom, which we prescribe to all of our children with diabetes because it's covered by California Children's Services, Dexcom said they'd be HealthKit compliant too. And suddenly we had the ability to put all the puzzle pieces together. We could take data from that child, run it through their phone or their parent's phone, and upload it directly into the electronic health record passively. Now, of course, our health record wasn't terribly great at visualizing this data, so we did a little work in custom visualization. So if you opened up any chart, you could see data points from the continuous glucometer for the last several months, and you could look at trends, turn on and off weekends. In fact, we had a patient who was way up in farther Northern California who would drive 4 or 5 hours for appointments, didn't like to come down, was under poor control, and the endocrinologist had no access to that data. Once we got them set up on this, their primary pediatrician locally did all the adjustments in consultation with the endocrinologist. Totally transformative. And when our pediatric endocrinologist found out that you could actually bill for reviewing this data on a monthly basis without seeing the patients, it suddenly went from being a pilot to being a program very, very quickly. The visualizing tool is available. It's freeware, so you could use it if you're interested. We published the outcome with the lead author of this project, Dr. Rajiv Kumar. Shortly thereafter, Dr. Kumar went to work for Apple, where I have no idea what he's doing because he's under NDA and can't tell me anymore, but I will speculate at the end of this talk a little bit. All right. I will say that half of this trial were teenagers. And guess who benefited tremendously from interacting with their physicians by text messages? The teenagers. But getting teenagers on patient portals is not an easy thing to do. And actually, we worked locally with Dr. Cindy Kelbs here at Rady Children's Hospital, as well as some other folks, to figure out how do you meet the privacy and confidentiality laws for the state of California. And it is possible. UC San Diego has teenager proxy access now. Rady Children's has it. And I would challenge all of us in the room to move forward in that way because it can be very transformative for care. All right. There's certainly other mechanisms of viewing physiologic data, in a mobile app. One of them that I'm using is the Withing Scale, and you can see I'm making a little bit progress on my goal there, but I took the y-axis off for privacy reasons. All right. So images come up a lot. Can't give a talk about big data without thinking about images. And traditionally, we think about those images in the hospital setting, radiology and pathology, dermatology, ophthalmology, things like that. But increasingly, those images are going to be available directly to patients. Anybody see this episode? You saw that? Do you remember who that is? So that's Eric Topol from Scripps Research Institute there. And he's on the Colbert Report. And what's he doing? He's looking in Colbert's ear. He's using a product there funded by Vinod Khosla up at Khosla Ventures called CellScope. And CellScope was the idea that maybe we don't need otoscopes anymore. Maybe we could turn iPhones into otoscopes. And they, through an iterative process, 3D printed enough that they figured out basically how to do it. And we actually had a trial at Stanford for our ENT docs to use it. And it worked great. The ENT docs love it. They can put the images right in the medical record. But that's not really a huge market for CellScope, right? So if you look at their current business plan, they're marketing it not to physicians, but to parents. Wouldn't it be great when your child had ear pain if you could put that in there, take a picture, send it to the doctor, and have a diagnosis quickly? And that's the kind of disruptive innovation that we're seeing coming out of local companies here in San Diego and up and down the West Coast. The iCheck product there actually uses the known distance between the LED flash on the iOS device and the CCD camera to be able to calculate a refractive index and screen in children for amblyopia and strabismus, right? The crossed eyes that need to get patched, something that we often don't pick up early enough. These things are changing the way that we practice medicine, and it's putting more power into parents and patients themselves. Also can't give a talk about big data without talking a bit about omics. right? Microbiomics and genomics and proteomics. And so you've heard about some of the companies that do this. The largest sequencers in the country now are two companies. One you've seen the commercials on, right? It's 23andMe, founded by Ann Wojcicki, former wife of Google founder Sergey Brin. The other is a company called, anyone know? Ancestry.com. Yeah. So Ancestry and 23andMe, their biggest business is actually ancestry lineage. But 23andMe, as you know, has been pushing the boundary on sequencing for medical purposes. And I actually signed up before the FDA prohibited them from sharing. So I got drug response data. And it turns out that my response to Hep C treatment is decreased. Fortunately, I don't have Hep C. My sensitivity to Coumadin or warfarin is increased, and the rest of it is pretty typical. And when I got that, I thought, well, you know, when I'm 70 or 80 and might need to go on Coumadin, then that could be important, right? Now, unfortunately, I have some increased risk from a disease standpoint for type 2 diabetes and atrial fibrillation, which incurred me to get that withing scale. But fortunately, I have some decreased risks like Alzheimer's disease and psoriasis. So, I got my reports, and I kind of, that's interesting. I'm a physician, it could be helpful at some point, but it wasn't really helpful then. In fact, the most interesting part of it was looking up second and third cousins, right? Until I crashed my bike. And I was hospitalized for 8 days with 2 separate surgeries on 2 separate dates, one for my right arm, one for my left arm. And I didn't fit the protocol for DVT prophylaxis because I had only upper extremity injuries. So they didn't consult the internal medicine service, which probably would have put me on more aggressive prophylaxis. And so a week after discharge, when I started getting knee pain and a fat thigh, and I thought, oh shit. I went back to the emergency department. Quickly, the ultrasound confirmed I had a blood clot in my leg. And the resident came by and he said, it's protocol, we're going to start you on Coumadin. And on my mobile 23andMe app, I pulled it up and said, well, I have increased sensitivity to Coumadin. And he said, what? And we actually looked up the SNP, looked up the dosing recommendations, and instead of starting at a normal dose, I started at a half normal dose. Totally different approach to patient management and engagement. Now, social data is another really interesting source of data. Lots of you on Facebook, which just announced they hit 2 billion people in the world, right? Lots of you on Twitter. Hopefully some of you are tweeting. But there's a few networks from a healthcare perspective you may not have heard about. So there's a company called Doximity, is a LinkedIn for physicians. 3 out of 4 US doctors are on this tool. And it allows discussion about patients and patient data in a HIPAA-compliant environment. But there's another company I want to talk about, started by a friend of mine named Jared Heyman. Now, Jared was on the cover of Inc. magazine because he sold this company he started in the early 2000s that crowdsourced stock picks. You got crowdsourced ideas for which stocks to pick. And it turns out this company did really well. And so Jared was on the cover of Inc. magazine on his motorcycle because he decided to take 2 years off and go around all of South America on his motorcycle. Really interesting guy. He cut his vacation short when about halfway through, his sister was struggling with medical issues. And she was actually in Northern California and had been seen by a number of experts and specialists and didn't have a diagnosis. In fact, she ended up at the NIH where she was diagnosed with a very rare disorder. But by the time she got there, it had been 14 months and 26 specialists, right? What's the number one cause of medical malpractice lawsuits in the United States? Delayed and misdiagnoses, right? We talk a lot in patient safety about medication errors. That is the tip of the iceberg, right? How many of you in this room know somebody who either had a delayed or misdiagnosis? Statistics show it's more than 1 in 2, probably 3 in 4 people. So Jared saw this problem that his sister had had, and he saw this company he had founded that crowdsourced basically stock picks. And he put the two of them together and came up with CrowdMed, which leverages the power of the public, not physicians, not clinicians, to come up with diagnostic ideas in challenging situations. In fact, the name for the people that are doing it is called medical detectives. Get it, MD. And his tagline is, what's better than one person Googling for a diagnosis? Thousands of people Googling for a diagnosis. So add in a little bit of wisdom of the crowd. So he told me about this, and I will be honest with you, I was quite skeptical. I had actually just been on the ward service where I had another zebra case, a teenager with a disorder called pediatric autoimmune neuropsychiatric disorder associated with strep, or PANDAS. And she got admitted routinely for IVIG treatments and steroids during flares. And I said, you know, this is a great example. It took her months to get diagnosed, and she ended up at the NIH as well. Why don't we, with parents' permission, run her case through your system? So we did that. And what you can see at the bottom here is the actual results of that trial. And so too little to see, but it's not a multiple choice test. It is a vignette with some supporting lab results and things that are posted. And then the crowd comes up with potential diagnoses and votes on them over time. We left this open for about 3 weeks, and what you're seeing there is the whole 3 weeks. And in green, can anybody in the front row see this? In green was the number one voted diagnosis at the end, and it was PANDAS. And I thought, all right, Jared, maybe there is something here. And so we actually got all of their data for a year, about 300 and some cases, and we did a research study looking at the impact on medical care for those patients. And true enough, we found that in many cases, probably over half, it was resulting in faster time to diagnosis and lower costs to the health system overall. Again, talk about disruptive change, right? Sometimes you hear about people asking their neighbors for help or their doctor friend across the street. How about asking 1,000 people for help? All right, so that's social data. I want to shift gears now and talk about the elephant in the room, which is electronic health record data. And I know many of you in HIMSS are working on electronic health records. We've got a lot of big deployments here in San Diego. Many of our affiliate physician practices are switching over, and lots of things are happening in the Southern California market. What does that mean for patients? I love this slide because to me, this was one of those slides that was like a complete shift in thinking for me. This slide was shown by the CEO of the company that makes the electronic health record that we at UC San Diego use. And she showed it and said, across our top 12 largest organizations, we did a little study, and we found that on a daily, weekly, and monthly basis, there's more access to this health record at these 12 client sites by patients and families than there are by your staff and your physicians. Now, they're doing very different things, right? Your staff, your physicians, they're in there all day long, unfortunately all night long in some cases, right? But whose record is this? When you start thinking about this as the patient's record, you start thinking about things differently. So in full transparency, here's some of our statistics at UC San Diego. This is a little bit old data for last fall. Shows that of patients that had been seen in the last 3 months, almost 1 in 2 had a patient portal account. You also see some of our top departments there are primary care areas where we've really focused on it, and some of the bottom areas were student-run clinics where we have not. What's important about this is that the patient portal serves as a substrate for a lot of our activation opportunities moving forward. Things like open notes, things like open scheduling, and video visits. So let me give you a little bit of an example of that. Who here knows what Open Notes is? Okay, I hope by the end of this presentation, everybody can raise their hand. You can check out myopennotes.org. Open Notes is when the physician notes are in the patient portal. That's it. When we started putting lab results in patient portals 5 and 10 years ago, what did the doctors say? Oh, I don't know if I want the patients to see what if they see them before me? And what's happened? It's been a great thing for patient engagement, right? Patients love it. It's one of the top 3 rated things in every patient portal. You love it if you've experienced it, right? In fact, at UC San Diego this week, we moved to releasing results same day for all normal results. But what about notes? Well, since 1996, when HIPAA was passed, we've had an obligation, responsibility, accountability to share the entire medical record with patients when they request it. So it turns out notes are available to everybody today, but you have to walk down to the HIMSS department and pay 10 cents a page to get it. The meaningful use legislation tried to make patient portals, push the boundaries, focused on things like lab results, but didn't mention physician notes, unfortunately. And again, 10 years later, physicians are saying the same thing. Well, what if they read something and they misunderstand it? What if, this, what if that? Well, funded by Robert Wood Johnson, great group out of Boston, Seattle, and elsewhere, did a number of studies. They've published over 20 papers on this. And once again, guess what? Turns out opening notes up on the portal is a good thing, and it engages patients more, helps them better understand their problems and diagnoses and physician thought processes, ask better questions, and it didn't increase calls to doctors. What it did do, though, and this is a separate paper I'm not showing, is it encourages patients to correct inaccuracies in their record, which is a critical benefit. So when I fell off my bike and I got a blood clot, I was lucky because our interventional radiology group was doing something called thrombolysis for my DVTs. They actually went in through my veins, my saphenous vein, and removed the clots with TPA. When I got down here to Southern California, my physician said, "What?" And I said, "Oh, don't worry. I've got the note. Here, you want to see the procedure?" On my phone at my visit, because where I came from, they had Open Notes. Now, UC San Diego is aggressively moving for Open Notes in primary care, and I would challenge all of us in this room and all of Southern California. This is my challenge for today, Clark. We should all be working together to release notes to our community. I know that there's some other organizations in San Diego that are working towards this as well. I think this is a great opportunity for HIMSS Southern California to take the lead. Let's open our notes up for patients. Okay, the benefits are tremendous, the downsides are minimal, and other communities have done this. We may be competitive in some of our health systems, but I am personally committed to collaborating within IT and informatics. We'll share all of our lessons learned with anybody who's interested. When Portland did this, Kaiser, Legacy, OHSU, the VA, and others in town all collaborated and came up with the same standards for when they'd release notes and what they'd do and their policies. And we could do this here in San Diego and Southern California. So hope I will leave you with this idea, but we'll go on another thing that you can do on the patient portal, a little bit less clinical, scheduling, right? When we moved down here with my 2 kids pictured there, slid them in, my wife said, "I'm not going to take them to a pediatric practice where I can't schedule an appointment online." I said, "Honey, don't worry. Most of them are affiliated with Rady Children's. They got the website." She says, No. I don't care about the website. It has to be on an app on my phone." I said, "This is how you're picking a pediatrician?" She says, "Well, no, you're at home. You can double check all that stuff." Fortunately, we found a practice, and it turns out all Rady affiliated practices in San Diego allow booking for urgent care appointments, primary care appointments, well child visits online on an app. We've recently launched video visits at UC San Diego, catching on like wildfire because we've taken a mobile-first and perhaps mobile-only approach, building on some lessons learned up at Stanford, where we pioneered these with our EHR vendor. We were driven nuts by a 50% failure rate. 1 in 2 of our video visits were failing because our doctors were in Citrix on, like double desktop environments, and they had one desktop for the video and one for the, typing their notes and the system. And then the patients were at home, and they were coming off a desktop, and we didn't know what video drivers they had, and we were trying to support them by phone, and it was a disaster. It was a nightmare. And so as our EHR vendor has integrated this into their mobile apps, which are available for both iOS and Android, we at UC San Diego have said we are supporting video visits on the mobile platforms only to start. And so we've actually just in the last couple of weeks had our first visits. We have whole clinics like our coagulation clinic that is really excited to take these and expand them rapidly. It's a built-in process for scheduling, even self-scheduling a video appointment for follow-up visits. And I'll tell you, the patient experience is awesome. I did a live demo at our recent telemedicine summit at UC San Diego. Of course, as a CIO, you kind of hold your breath for live demos. It worked seamlessly. The mock patient was in the other room. Our physician was on her mobile app for the EMR and clicked the button, and within seconds, up popped that patient, and you're right in context in the patient's chart, and it records the amount of time that you're in, and it drops some of that information in your note for billing purposes. It's great. This is the future, and again, it's built on patient portal, right? Now, I mentioned earlier that unfortunately some of our clinicians spend not just all day, but all night in their electronic health records, right? We know that physician burnout is a real thing, and we know that electronic health records are contributing to it. If we don't acknowledge that as an industry, we're going to be in a deep load of problems. What can you do to mitigate that? Well, there's all sorts of things. There's ongoing training. There's building the system to be more user-friendly. There's working with your vendor to make the buttons require less clicks. But you know what else there is? There's rethinking the process. Right? Now, we have to put certain things in our notes to bill for a CPT 99234, right? We have to put it there, but you know what? I don't have to put it there as a doctor. And the regulatory people say, well, yeah, but you can't bill off a medical student note. You can bill off a resident note, but you have to attest to it, right? Well, you know what you can attest to? Patient note, right? So if you roll out pre-visit questionnaires to patients and they fill it out on the portal before they come, and it pre-populates the physician note, guess what? That physician now has to type 50% less information. Sutter, which is the nation's largest single instance of their particular EMR platform, Sutter rolled this out aggressively in their pediatric practices for well-child visits. So what sort of outcomes do you think that they found at the end of a 6-month trial period? Were patient visits shorter or longer? Patient visits actually, on average, were 2 minutes shorter for patients who had filled out the pre-visit questionnaires. Okay? Patient satisfaction, go down, stay the same, go up. Who says that it went down? Who says it stayed the same? Come on. Up. That's right. So the visits got shorter, the documentation burden got less, and the patient satisfaction went up. And you talk to the Sutter pediatricians, which I did, and we're writing this data up. Why? Well, if the patient's filling out that form that used to be paper that you'd go through every step, and they're doing it online in advance, and then it defaults and pre-populates my note, right? And the abnormal things or the things where the parent showed concern are highlighted in red. What am I doing in that visit now? I'm focusing in the areas where parents have concerns. And so the parents felt like, and this came out in the comments, the doctor spent more time in the areas where I was concerned, more time addressing what was bothering me. And the doctor said, having the data already in the note was fantastic and allowed me to spend more time with the patients and their families, right? So this is a no-brainer. You see some of our optimization work there. This is one of our physicians before and after optimization. The y-axis is time of day. And the bottom line there is that that physician was spending less after-hours time documenting. You want an aggressive strategy for optimizing physician utilization of the EHR? Engage patients. And what can you do after visits? Well, you can collect patient-reported outcomes. The NIH makes these open source because they spend a bunch of federal money validating that. How do you track progress in a lupus patient? Well, it's a survey. It's a patient-reported outcome. So lots of opportunity here. And again, it's hinging on use of the patient portals. And the use of the patient portal, as we've seen locally and throughout the community, is increasing on the mobile and decreasing on the web. Something unique that we do as the only academic medical center in town is clinical trials. So unfortunately, 85% of clinical trials fail to retain enough patients. And I will tell you the dirty laundry, 50% of our trials at UC San Diego go unfilled. But guess what? 50% of trials at Harvard go unfilled. It is difficult to adequately recruit enough patients. So what helps? Outreach to patients. Don't wait there for them to come. Find the patients, right? We recently extended our UC San Diego instance of our EMR to UC Riverside, and we're in the progress, with help from Sri, of extending it to UC Irvine as well. We're doubling the patient population that we're serving, and we're going to be able to jointly recruit for trials at both Irvine and San Diego through patient outreach. So another transformative approach. Hopefully, all of you have seen the new building that we opened just before Thanksgiving. We're proud of the Jacobs Medical Center. That tech award that Jeannie mentioned was in part because of the work that my department did opening this great building. And one of the neat things about the building is that every single patient room has a tablet and an Apple TV. And the tablet doesn't just enable access to the medical record, it also has built-in IP room controls. So there's a big glass building. As the sun sets and things get hotter and cooler, patients can control the blinds on their own, and they can control the lights on their own. And I'll never forget the first time I was seeing a postpartum mother after this opening, and I saw she'd used the tablet, and I said, "What do you think?" And she knew me as a pediatrician for her baby, not the guy that runs IT. So I think it was an honest answer. She said, "I love it." I said, "Why?" She says, "Well, as you know, I had a C-section." She says, "I can't get out of bed, it hurts. And my husband went home to take care of the first child, so I was by myself on the second night." She says, "I had control over my environment. I could adjust the temperature and the lights and the blinds and stream movies, and I could do it all from right here." And I said, "Well, what about your medical record?" She says, "Yeah, I'm accessing that too. What she really wants is to access the baby's chart, and we're working on better workflows for that." But what we're finding is in the community using this MyChart bedside, we have some of the highest activation rates across the nation. So more patients who have access to this are actually using it than at other places in the country. And our hypothesis is it's because people hear, "Hey, this iPad's great. It's going to control my lights, the blinds. I can stream Netflix and Hulu." But once you're using it, you see that icon that says, "Hey, here are all the benefits of getting into your medical chart." In fact, we're rolling out secure messaging to all of our physicians and nursing staff. In the next phase, we'll be including patients. Why? Not because the doctors are asking for it, because it's the right thing to do, right? Because we, the patients, are part of the care team. Now, not all interventions have to be high-tech. You heard some of the non-high-tech interventions in the great keynotes this morning. And I will say one of the things I've done I'm most proud of, this was up north at the last hospital I worked at. And it was after we converted our electronic health record. And of course, the interns and residents and physicians and bedside nurses lost that big flow sheet by the bedside, right? And we did a whole lot of work to give them access to a new flow sheet that worked just as well and summary screens and all that. But you know, it turned out there was someone else who'd lost it who I hadn't thought about. It was the parents. Because in the neonatal ICU, you can predictably know that a baby born at 28 weeks is going to stay in house 6 to 8 weeks. And after the shock of the first week wears off on those parents, guess what? They start coming in and looking at the flow sheets just like the interns. How much did Johnny stool overnight? What was his last bilirubin? I want to know, is he gavaging his feeds, right? Anyone here of parents of babies who spent time in the NICU? You remember, 2 babies. So we rolled out something fairly low tech where we used the data from electronic health record to actually print out a letter to the parents of all of our patients in the neonatal ICU. And the letter you can see says, here's your baby's care team, and here's the solutions that they're eating, and here's how much they stool, and here's the recent lab results. And it was a paper letter. It didn't require tablet or patient portal access, but we put it by the bedside of every patient. And I'll tell you that initially our attending physicians weren't real excited about this. But we had a couple who were co-authors on this paper who really championed it. And the great thing was, when they were on service, they would write these little sentences at the bottom, wean the ventilator today, keep up the great work. And our family advisory council told us, you know what, these are refrigerator worthy, right? These mean a lot to me. And so when the attending physicians who were championing this went off service and the next one came on and maybe didn't want to do it as much, guess what happened? The family said, where's my letter? The families demanded the letters, okay? In fact, we showed in our survey data that these letters were equivalent to a nurse or a physician in terms of quality of information and better than other sources. We also showed that the nurses loved this because they were less asked by parents to look up data in the EMR and things like that. What was really great, though, was we had this annual sort of leadership symposium, and we'd always invite a guest speaker from our family advisory council. And about a year after we rolled this out, our guest speaker, unbeknownst to me, was the mother of NICU graduates, 2 twins. And she described her journey in our NICU and what it was like. And this is somebody who wasn't coming from a healthcare background. And she got up there, and again, unbeknownst to me, she picked up this big stack of papers, and she said, do you know what made me feel better? She says these letters I got every day made me feel empowered, made me feel more ready to go home. And that was when I knew we had done something really special. And you know what? We did it without any new technology. You could do it today. So there's both high and low tech interventions. Now I promised at the beginning that I'd bring us back to where my buddy Dr. Kumar is doing at Apple. But this takes me back to almost 10 years ago now, when I sat on the Google Health Advisory Board. Anybody remember Google Health? Right? Like a lot of tech companies, Google decided that they were going to get into healthcare, they're going to make a difference, their smart engineers could solve healthcare problems, right? And as a member of the advisory board, I helped to advise them on how to make their personal health record pediatric friendly. And it was a really exciting time. As a faculty member at Stanford, I got to spend 20% of my time on outside activities. So I went over every Friday for about 6 months to Google. I ate in the cafeteria, worked with the health team. It was pretty cool. When we built the product, I thought, man, wouldn't it be cool if we plugged it into our hospital? So I talked to our CIO, I talked to our CEO, I said, hey, this is the future. Interoperable health records are going to allow health record data banking, right? You can make deposits and withdrawals as a patient, you're at the center. And they signed off on it. We invested some money, not in Google, which didn't charge for it, but in creating the interfaces to our EMR to upload these CCD documents on demand by patients. And we got about 75 patients enrolled in the first 3 months before Larry Page announced on the quarterly stockholder report, Google Health really hasn't had the adoption that we want, so we're pulling the plug. That was a bummer. What we found in our survey data of those 75 patients was that what they really wanted, number one, was to be able to message their clinicians. And you couldn't do it in this PHR, or interoperable personal health record Google had built. The second thing they wanted was to be able to schedule appointments. And you couldn't do that either. The third thing that they wanted was access to results, and that's what this did provide. But that fundamentally shifted our direction more towards these tethered patient portals. So we published a paper about our experiences with it, but I find it very interesting that now, 10 years later, there's rumors in the press that Apple wants to make the iPhone a one-stop shop by allowing you to download your medical record to your mobile device. This came out a week and a half ago. I have no insider knowledge. This was published in the press. I did hear that they were a little pissed that it was published. What does this mean? Will it be different this time around? I don't know. What I do know is that 10 years ago, when we were doing this with Google, there was no iPhone, right? So will mobile technology, along with big data, make the difference? We will see, and I look forward to being part of it. I want to close by acknowledging a hero of mine and a hero of medicine who passed away last month, Dr. Larry Weed. If you don't know, Dr. Weed famously invented the soap notes that we use ubiquitously in medicine today. And there's a great lecture he gave in 1971 that's available online. Grab a bottle of wine, pour yourself a glass, kick back and watch this. It's wonderful. I had the pleasure of meeting him in 2013, and I had him autograph his paper from 1969, where he wrote, "Patients are the largest untapped resource in medical care today." Almost 50 years ago, patients are the largest untapped resource in medical care today. Unfortunately, continues to be true. This room can help to change that. So thank you very much for having me. I really appreciate it.